the UCSF Helen Diller Family Comprehensive Cancer Center, CAB2, ChatNChew, and I just want to remind everybody we call it the CAB2 because we have our business meeting for our community advisory board, the CAB, that I think of that as CAB1. This is CAB2. This is open to the public. The 2 is also a reminder that we want you to invite 2 people. Once we have you on our list of email addresses, you're going to keep getting invited to this forum until you tell us to stop. We want you to invite or advance that invitation to 2 additional people so that we can continue to grow the network and make sure that people get access to this super important information. If you miss the presentation, it is available on our website at UCSF. It's cancer.ucsf.edu, and if you search on that site for community or community engagement, you will find our website. I'm sure somebody is going to throw it in the chat before the meeting is over. But without further ado, I would like to introduce our guest speaker. So I think this might be one of the first times that we're having someone from outside of our institution share your wisdom and your work with us. So please join me in welcoming Dr. Sora Tanjasiri. Dr. Tanjasiri is a professor in the Department of Health, Society, and Behavior in the program in Public Health, and the Associate Director for Cancer Health Equity and Community Engagement at the Chao Family Comprehensive Cancer Center at the University of California in Irvine. Her research focuses on community health promotion to reduce cancer health disparities among diverse populations, particularly focused on Asian Americans and Pacific Islanders. Her work applies community-based participatory research, or CBPR, to tobacco prevention and cessation, to cancer early detection and survivorship. And she's the PI or co-PI on over a dozen extramurally funded, so federally funded or funding that comes from outside our institution for cancer-related studies. And we do work together in another one of those spaces. So again, I want to welcome the Health Equity Action Network into this space as well. Dr. Tanjasiri serves or has served as an advisor to a number of community-based organizations, including the Orange County Asian Pacific Islander Community Alliance, the Asian Pacific Partners for Empowerment, Advocacy and Leadership, the Orange County Women's Health Project, and the St. Joseph's Health System Community Partnership Fund. She got her DRPH in Community Health Sciences and her MPH in Behavioral Sciences at the UCLA School of Public Health. So without further ado, I want to pass the mic to my colleague and friend, Dr. Tanjasiri, and welcome you into our space.
Oh, thank you so much, Kim. And for everyone, please call me Sora. And I always consider ourselves part of the same system, the UC system. So we are sister campuses. And it's a pleasure to be here. Let me share my screen. I'm actually particularly thrilled because what I understand is that this was a request from this esteemed group, to learn more about community engaged approaches with Pacific Islander communities. So I could not be more thrilled about speaking to a group of friends and interested colleagues about this topic that's been a passion of mine for many years. Okay, so I want to start a little bit with what I hope are just some realistic goals. I wanted to just describe a little bit about what we know about cancer trends in Native Hawaiians and Pacific Islanders in the US, to identify what are some of the hallmarks of community engaged research approaches, and then to share with you some examples of what this has looked like over the course of a bit of my career and what it looks like now. I am not Pacific Islander. I want to start with that. I am Korean by ethnicity, but born and raised pretty much here in California. So my work with Pacific Islanders has really come from just some really wonderful opportunities to learn about the community, to partner on common causes regarding cancer and other issues, and to really learn about how to do work that can hopefully lead to both in fact, impactful research, but also sustainable community capacity and another building. What I've been schooled in is to really start with, where do Pacific Islanders come from? Those in the United States could have been here for lifetimes, for example, Native Hawaiians in Hawaii, or from kind of 3 different regions of the Pacific. So Micronesia, Melanesia, or Polynesia, which is where Hawaii is and which is where I currently am. I think it's really important to know that many of these regions are affiliated with the United States. In fact, we have 6 US affiliated Pacific Island or Pacific Islander areas, including the 6 that are listed. And you can see that they really span many different areas of the Pacific. And I do want to mention that, although we won't have time today in the presentation, that each one of these areas has a different kind of relationship with the US. Some, of course, are states like Hawaii. Some of them are freely associated, meaning they can come and go without passport into the continental US. But some do and some do not have rights, for example, regarding access to healthcare programs that are available to all Americans, US, in continental US. And I think that that's a very important reason why some disparities exist. Okay, so what is a snapshot of Pacific Islanders? So I hope you already know that we have over 1 million in the US, that the largest ethnic groups are Native Hawaiian, Samoan, Chamorro, Tongan, Fijian, Marshallese, and others. Because of affiliations with the US, nearly 85% are considered US born, only 15% are foreign born. And you can see the educational attainment, 25% have bachelor's degree or higher, almost 90% have high school diploma or higher. So you would think that this would lead to hopefully minimal, if any, health disparities in populations, but unfortunately that's not the case. So what do we know about cancer control needs among Pacific Islanders? The quick answer is not enough. And the reason is for a few. I want to always highlight the fact that we do a significant injustice to Pacific Islanders here in the US by always aggregating them with Asian Americans. And I don't want to say always, but in the world of cancer, for example, the American Cancer Society, facts and figures from this year, continues to aggregate Asian Americans and Pacific Islanders together, thus masking the differences and the unique cancer needs of Pacific Islanders. It's not just on a national level, but this is true also in California. And when we're talking about readily available data, now you can go and get cancer data from California Cancer Registry or from CEnR, and you can then disaggregate data to the extent that the patient data has identified the ethnic racial origin of each patient. But you can see for CCR in the California Maps interface that we still continue to aggregate Asian Americans with Pacific Islanders. And so by no surprise, you might imagine then that we really think that the needs of Pacific Islanders regarding cancer control is fairly low. But many, many smart colleagues, including those at USC and at UCSF, have taken a deeper dive in terms of trends. This is age-adjusted cancer incidence, with the left hand being Native Hawaiians, the left hand is non-Hispanic whites, middle chart is Native Hawaiians, and right hand is Samoans. And you can see that there are differences. If you just look at breast, you can see non-Hispanic whites, the incidence lines have been relatively stable. There's been some greater changes among Native Hawaiians, and it looks like an upward trajectory, specifically among Samoans. And if you can look at colorectal cancer, you see that non-Hispanic whites, it appears to be decreasing. It has been decreasing. Same for Native Hawaiians, but potentially increasing among Samoans. Now, I could do a presentation alone on the limits of data, but I do think that there is a take-home message here, and it is not just around cancer control. So we are hopefully emerging out of the COVID pandemic. And what we know that happened during COVID continues to happen in cancer control, continues to happen in cardiometabolic disease data analyses, et cetera, which is that we are not disaggregating data despite the federal mandate. And so I love to talk about the work that Calvin Chang, Karina Penaya, Carla Thomas, and others, particularly affiliated with the UCLA PI Data Lab, have shown. That what we know about COVID in the first year of the pandemic showed that the rates of COVID deaths was highest for Native Hawaiian Pacific Islanders. And the problem is that in 20 states, up until 6 months into the pandemic, 20 states in the US did not even disaggregate data for Pacific Islanders. So when you do a deeper dive, you can really find the fact that there are disparities. And this is what we need to do more work on. I think there are people who are on this call who are leading that charge in many different ways. And I want to call out the Regional PI Task Force for contributing to the data collection and the reporting of a lot of the COVID-specific aggregated disparities. Okay, so what does that mean for cancer control? I want to also say that beyond data and getting access to data to be able to convey the need, there are a lot of negatives to overcome. And these are negatives from outside the Pacific Islander communities. And I think outside those of us who are researchers that do work with ethnic racial populations. Let me just give you a sense of what the criticism I have come across when I have, developed grant proposals or written papers for publication around what it means to be working with what I put in quotes, small populations. These are not insignificant populations, but for instance, because of the data problem, the cancer-specific needs of Pacific Islanders are unknown or perceived to be low. So I always get asked the question, well, how are they a priority population in cancer control? It's like, going on. Well, because they're so small, what's the generalizability to other larger populations? Oh, well, no one knows how to reach Pacific Islander populations. Can you actually successfully recruit them into studies? Or there are so many complex language, social, cultural, and community needs. What's the greater feasibility of a research proposal and project? Or finally, underserved communities have too many non-cancer needs. What's the sustainability of this work, beyond the actual research project? And so I will say that for those of you who probably are nodding your heads, because in the work that you do with populations, you've come across one or more of these real barriers, that working in research is also a heavy lift, because we have to make the case for the importance of these populations. So again, the pleasure I have partnering with communities to be able to communicate these, educate our fellow colleagues and funders to be able to support this work. Okay, so let me shift a little bit to the way that I think this work should be done. And that's really in this community partnered or community engaged approach. I really think this is where identification of needs starts. It's because those folks out in communities who are doing clinical services or primary care or community services, they're nonprofit organizations, they see the needs. Oftentimes it's through their work that they come and teach others about what they're seeing, and hopefully are inviting us to be part of research questions that are deriving from these observations in communities. And when this beautiful synergy between service, teaching, and research comes together, I think that overlap is really the opportunity for community engaged scholarship in partnership between communities and universities to address pressing needs and build upon community capacities and assets. And the way we do this is through principles that have been codified in many, many different kinds of writings. But in general, those kind of major approaches are this requirement of close collaboration. So I, in the work that I do, really go beyond maybe what sort of necessary but sufficient approaches, like, for example, having community advisory boards, CABs. This is a wonderful, very initial step of doing community collaboration. But I ideally seek out collaborations with community leaders, community members, service providers who themselves really understand what's going on in communities. And then we engage in a process of co-learning. To the degree that they're interested or have the need, it's my privilege to be able to share and talk about what kinds of research designs or research methods might be able to address community research questions. And I must learn about what it means to have community needs in a certain context. Most of the work that I've done is in Southern California. I will end, though, this brief presentation today with some lovely work that's been going on here in Northern California. Once we've engaged in co-learning, which, by the way, is ongoing. I'm never too old to learn something new about the ways to do community engagement in research. Then we engage in shared decision-making on the research questions, design, implementation, analysis, and dissemination. And then ultimately, we're focusing on sustainability for long-term benefits, right? So it's not just what are we learning from the research, what do we report in publications, and then we're done. But what are the next needs? How does this feed into opportunities for community organizations, primary care providers, others to build upon this work? So let me give you an example. It kind of dates many years back when I was working with a group of leaders in Southern California. And they were interested in understanding what is the health status of Pacific Islanders generally. And we were doing deeper dives into available research and available data. And we're finding, for instance, higher rates of obesity among Pacific Islanders compared to other racial ethnic groups. And we called this partnership WINCART, Weaving an Islander Network for Cancer Awareness Research and Training. So many of these leaders indicated that they were seeing low rates of physical activity and believed it was a priority health concern for their communities. Because quite honestly, they were telling me that by the time that we're trying to promote, for example, cancer screening, it's oftentimes too late. What they wanted to see was a real focus on prevention and primary prevention. And so we undertook really a call to action to try and identify and adapt a physical activity intervention and then evaluate this in communities. What is wonderful about this work, so I just want to say that many of these, I do some training in different training programs. And so many of these leaders became trainees and went on to get their higher degrees. And so they are now researchers in their own rights. But so, for example, a little over 10 years ago, we undertook a study. It was a 2-year study to assess the feasibility of various obesity, physical activity, and nutrition assessments among different ethnic groups of Pacific Islanders. We wanted to try as much as possible to estimate prevalence of these and explore factors influencing physical activity. What we were able to establish is that we could do this work. And when I say we, I mean our community partners. They helped design the study. They realized that they wanted to go out to communities, so not necessarily people who are only coming into clinics, right, for services, but actual community members. We found a recruitment rate of 65%. Among the people who agreed to participate, 100% completed surveys and did various height, weight measures. And then we found a retention rate because we did some food and physical activity monitoring over a 1-week period. And we found 99% and 88% retention rates. And we were able to confirm higher rates of obesity, caloric intake, and lower rates of physical activity. So not a problem. This can be done if it's community engaged. So fast forward then, we were looking for ways to be able to impact this. And a dear colleague at UCLA, Dr. Tony Yancey, had developed this Let's Move model, which is really this notion that with short bouts of physical activity, as short as 10 minutes a day, you can improve cardiometabolic profiles, maybe not reducing obesity, but certainly improving health status of individuals. And we took that, we applied the National Cancer Institute Research Tested Interventions Program, this kind of adaptation approach to Pacific Islanders, and then said, does this work? What I love about this is that the community challenged us to develop an array of audio and visual materials to disseminate to communities. And we did this strategically through organizations, specifically churches. So we went out and recruited Pacific Islander churches and then individuals within those churches and basically asked the question, are you interested in this physical activity program? Would you be willing to do this? And what is the outcome, both immediately and after a few months? What we found out is at baseline, we did find that prior physical activities were distributed, you could see, but 24% did not have any regular physical activity nor any intention to do such in 3 months. But that after we did this intervention, applying the Let's Move model, you could see that we had over 50% both that who were involved in this and had the intention to continue this ongoing. And that when we looked at the organizations, so this is where looking specifically at the 8 organizations, we found that 5 of them were actually able to implement all components of this program. And it included not only dissemination of those materials I showed, but the identification of a program champion, the training of that champion, and champion-led physical activity breaks during church activities. And at the end of the program, we found that 5 were interested in continuing this ongoing, which we thought was wonderful. So, and you can see we published on all of this, which is wonderful. But back then, the community said, well, this is great. We developed this, but this is for churches. And we know a lot more Pacific Islanders who would benefit. So they themselves launched what became known as the NHPI Youth Health and Fitness Day. It was initiated as part of a kind of Southern California community-wide approach. It was held at UCLA and sponsored by the California Endowment. But as it morphed, it became housed within the Pacific Islander Student Association at UCLA and ongoing, off and on over the years, of course, stopped during COVID. But what's wonderful is it found a home. The focus is on Pacific Islanders, on families, and the message is about health. So after all of this work, I want to say now fast forward. I had the enormous privilege of being approached in 2019 by members of the Regional Pacific Islander Task Force with the question, would we be interested and able to work with churches, Samoan churches up here in Northern California, and to basically implement or lay the foundation for an implementation of wellness and prevention approaches, including physical activity and nutrition. So we wrote and were funded for the Samoan Healthy Eating, Active Living, or Samoan HEAL project. It had 2 different components. We replicated what we did in Southern California. So we worked with churches and church leaders to try and understand the degree to which they were interested in a physical activity and nutrition program. And we surveyed individuals from one church to find out what were their levels of knowledge, attitudes and needs, and interest. We found that 50% of the people we were interviewed, so these are individual survey results, were physically inactive. 60% ate vegetables and 64% ate fruits. And both of these were less than 5 times a week. I'm sorry, that's 5 times a day, not a week. I apologize for that typo. And 43% had self-reported fair or poor health status. We reported this back to the community leaders and members. And by the way, I want you to see the enormous number of surveys that were collected. There were 72 surveys that were collected with only a 25%, $25 gift cards. And this is during COVID that this was done. So that, along with interviews with 8 Samoan church leaders at 4 different churches, really showed us that even during COVID, if the interest is great enough, this is something that can be done. So we're in the midst of planning for the future, and we intend to build upon what is becoming known as now wellness councils in many of these churches that have been developed because they are interested in primary prevention and, of course, holistic care for their church members. I know several members, I believe several members of the Regional Pacific Islander Task Force are on this call. I saw Koa. I don't know if Chao joined us. But if you're here and you want to chime in, please do unmute yourself and feel free to share a few words.
Thanks for calling that out, because I've been chatting Chao because I asked her if she would share about just being involved in this kind of work and what that experience is like from the community perspective.
Yeah.
So sorry. Thank you, Sora and Dr. Rhodes. This is Chao, and I'm with the Regional Pacific Islander Task Force. And, you know, this has been such an overwhelming, process. And I have to say, from the community perspective, I've never, these are all learning experience. And with the church that was studied, I have to say this is the first time they've ever been studied and worked with. And the good thing is with Dr. Sora was that with her experience from Southern California, but just to her humility and being really understanding and open-minded with the community, is that she was very patient, but it was all about community, understanding the community, but coming from the space of understanding the community prior to coming in, especially with the faith base. There's a lot of protocols and culture, and Sora came in with that open mind and was able to schedule appointments in advance, making sure that got to know the meet and greet and getting to know the pastor and the leaders. So for us that are working with the communities, I have to say that, that type of approach, the humility and just understanding the community and just meeting communities where they're at, and just so happened this church have never been studied before, never done a survey. So, and then on top of it, there were COVID that we had to deal with. And there was a lot of back and forth, and I go, thank you. I go, Sora, hang in there. We had deadlines, and then thank goodness, UCI was very understanding. So that too, the flexibility and just understanding where the community is coming from, that really helped us. And then we also wanted to underscore many times in different researches, once it's done, it's done. They never came back and said, hey, here are the findings. Does this make sense to you all? And everything was, we were always, Sora was always there for us if we had any questions. So she was always available. And then those questions were not easy questions too. Some of it caught us off guard, but overall, I have to say this was a huge lessons learned for all of us as a community and the community leaders, is being patient. So Sora, thank you so much. We need to grow, we want to call it a Pacific Islander Health Research Network up here in Northern California. How's that, Dr. Rhodes? Because she's already started that. So thank you very much for the opportunity.
Is there anyone else from the network who wanted to share their experience in this process?
I'm scrolling through some of the comments. I see Koa made a comment about going to Kaiser last year and not seeing NHPIs when they're not disaggregated data, so the screening data as well. Thanks, Koa. So COA was also part of this Simone Heal project, as was Rox. So thanks, Rox, for your leadership as well.
Just wanted to share how important the capacity building was, and just to touch points. Often it would be me and Chao and the task force team, and then we pull in the UCI team, and then we pull in the church team. So a lot of just touch points, and so that folks could get used to what it means to fill out the survey online and getting like the gift card and like what it means, right, to contribute to that, and then sharing back the data to the community has been really instrumental. And now they're ready. I feel like now they're ready for a little bit more. So that's exciting too.
So I want to invite, thank you, Rox. I want to invite folks to put some questions in the chat. We do already have a few questions that we've captured out of the chat, but continue to put them in. You can also, Sora, I don't know if are you done with your slides, or do you have additional?
No, I actually only have one slide, which is, I think some of the comments are surfacing this, that really when we think about a research, so as a now principal investigator, not as a Pacific Islander, so the not so secret life of a principal investigator, we're always thinking about data. How can we get it and what can we use it for? But I think these are fundamental to community engagement, is the recognition about the limits of data, the importance of also relying on community experiences, because those will often tell the story that is not being told in the data, and relying on both to be able to move the needle in terms of research and ultimately what we're trying to do, which is justice for all, inclusion in data, involvement in research and data collection, and particularly on building upon all of those. And so that's actually it. I just was going to leave my email if anyone wanted to email me with any questions and to say thank you. And so we can open it up.
So while people are that was Tanjasiri at UCI, we're putting it in the chat.
Oh, thank you. At uci.edu.
And just Tanjasiri, no Tanjasiri.
Correct.
Okay, there it is in the chat for y'all. And I see that May just joined us from Neighborhood Breathe and wants to partner with PI Heal. So we'll make sure to make these connections as folks fill out the evaluation survey. But I want to first get to some of the questions that were put in the chat early on in your talk. And thank you so much for bringing this content. This is the first time that we have had content related to work in the Pacific Islander community. So really grateful for you for bringing this to our CAB2 ChatNChew forum. So one of the questions that was in the chat is whether or not, if you're aware, is there any data on Pacific Islander men and prostate cancer? And then if you talk a little bit about, and this is for you and for Chao, Rox, others who are working in this community, how might you reach men? And like, is there a model that you can kind of speak to reach Pacific Islander men? And I'm not sure, Michael, what you meant by this, but I think it's related to how we've been able to reach African-American men, and can that be adapted potentially?
So yes, there is some data available on Pacific Islander men and prostate cancer. Most of it you'd have to go and get the data yourself. So doing a request and a deeper dive, for example, in California Cancer Registry. I'll take a look and see if any of the work that Dr. Lynn Gomez and others have done, breakout prostate. I believe it has. I'm just not quite sure how old it is, but I'm happy to do a search and share it maybe with you, Kim. I don't know if someone's able to take a notes and just to send me like a to-do list.
Oh, no, we've got it, and we're going to connect you, and if people request through the chat here, we will connect those folks with you.
For the question about whether there are ways to reach Pacific Islander men, I think this is a perfect question for Chao, Koa, or others on the call who really know the community.
I think for So this past year, what we did was we held the first Pacific Islander Health Ministry health fair. And Michael and I think Stephen, that were both there from UCSF from the Men's Health. That was very powerful because, you know, Michael and them, they also experienced how hard it was to bring men to the conversation. And so we saw men were like, you know, they just said hi, bye, and then, you know, but they're walking with them as they walk away from them. And so, you know, they know how to do it. And I said, oh my God, this is so great. And then my husband was one of them. They walk with them and then they find, and you know, I mean, the actual inflatable colon was actually there too on the premise of our church. So all of these things were going, you know, parallel of one another. But I have to say, it goes back to the faith base. In the faith base, we have what we call the men's ministry, which is made up of deacons around, you know, for each of the congregations. So in many church, you always find in an opportunity, again, it goes back to really building those relationships on the ground. But that's how, you know, being a member of the UCSF health ministry through the Abundant Life. We started our church back in 2018, and it kind of spun off of that. And then when we had the opportunity, because I tell you, with COVID, the only people that came out to help us in distributing the food and opening their doors for vaccination and testing were the faith-based, were the churches across the whole Bay Area. And I mean, with that, we saw this window of opportunity to share with Dr. Kim Rhodes, hey, we're going to do a Pacific Islander Health Ministry. And then when we told her it was like 13 churches, you know, 5 Tongans, 5 Samoan, and 3 Fijian, she goes, what? I thought you were going to say like 3 or 5, but this goes back to what Sora was saying. It really, just kind of threading, the relationship, and just keep building where how you're building the community perspective, especially COVID, we're still, meeting the communities where they're at while recovering from COVID. And so that too is something to consider. But bringing our men in the conversation, it's difficult, but we also have other programs like our mental health program, the prevention and intervention. How do we have those courageous conversations? I think the bottom line is creating this space. If we create the space for our men, and have our own men, have them create the space for that. Just let them talk. And if you give them that space, it doesn't have to be facilitated. One of the things we do in our mental health is we call it talanoa for wellness, meaning just conversation, just talk. And I think that's what I hear that from my husband and some of the men in our church, is that we need more space to have those conversations. Doesn't have to be, facilitate, no topics, just talk. So, I look to lean in with Michael and Stephen from UCSF. I truly feel they have the magic because, they had to go through a lot, and I'm happy to, hear Michael a little bit to share that, of what he shared with us. And certainly, I think what best practices that has been tried, I think we can learn from that too. So I want to give a shout out to Brother Jake from Utah, all the way from Utah. So, Jake Fitusimalu Malo Soy Foot, thank you.
Thank you, Chao, for also that cross-reference on sort of what was being built in terms of the health ministries in Abundant Life that then flowered into this wonderful, the network of work that you're doing. I think it sounds like you even came up with a unique name that sounds like it's probably selected by the community instead of calling them health ministries. I can't remember what the councils, so that you have folks who are dedicated to health activities as they come through, and those opportunities come to the faith community. So really lovely adaptation. There's another question in the chat that I think some of the researchers would be interested in those who in the community who have participated in research. But usually the community engagement part of the research is deeply underfunded. We know this. And so it makes it difficult to allow for long-term capacity building, training, outreach, and sustainability. Can you talk a little bit about how the budgets have been crafted to, to drive equity, so that our community partners are also getting, really equitably compensated for the expertise that they're bringing to the table?
Oh yeah, I love that question. And I always say that if you want to know if something is truly community engaged, go to the budget first of a proposal and actually see if resources are being allocated equitably. So in general, I mean, community engaged research cannot occur unless there is equitable distribution of resources. Of course, depending on the aims and what is involved, that can look different. But I always ask the question. The first question is always, what's the research question, right? What are we trying to do together, and how might we do that? But my next question is, okay, what will it take to do this? And it usually is some form of subcontracts or consultant contracts and things like that. And so I'm always start with the question, what would it take? And I ask this of our consultants, of our community partners, et cetera. Usually gives us a starting point, and of the researchers. I mean, as researchers, we're used to this question. We're always being asked, would this take whatever percent effort or whatever percent, we've got some gauge. But in communities, I cannot assume to know what it will take. And so I always start with that question. And much like any research project, we always overshoot our aims and underfund our general approach. And so there's a process of discussing, okay, well, that's what it would cost to do this. What if we took it this way? Can we fit a budget, university and community? We're all part of this together until we end up with a budget that makes sense. I also always ask the question, who is the lead? Right? Because it doesn't have to be the university that's the lead on a research project. Now, certain funders require certain things of leads, and so you have this conversation. But maybe it makes sense for the community to be the lead, that they then manage the budget, and then they do the subcontracts to each of the organizations or consultants, including the researchers. I want to say at the end of the day, if we're not having the conversations and answering the questions about what it means, we will always be inequitably distributing the money. Because as university researchers, we know, our universities take 50, 60, 70% overhead. I mean, it's just incredible what the playbook is at the universities. So we've got to have these conversations with communities. What does it mean to have overhead? What does that cover? What does it mean to have percent effort? What would that involve? Et cetera. So there's no one way to do this, but I think there's a set process that has to happen, and it has to evolve over a series of meetings as you lay out the questions, you answer, subsequent questions, you build a budget, you ask everyone, is everyone comfortable in having the budget be transparent, right? With everyone's, so at UC's, Kim, you and I know, all our salaries are transparent. Anyone can Google us and find out what our salaries are, but that's not the same thing for community. And so I have to make sure, does everyone want the budget to be transparent, or should there be some sort of, confidentiality and just bottom lines that are known? What's the process for putting this together?
And can you, Chao asked just to extend on this question, can you also talk about community members becoming co-principal investigators?
Oh yeah, I love this question. Yeah, so I think also that community engaged research should also involve meaningful leadership from communities. Now, I understand that I have the full-time research job. Communities don't have full-time research jobs. Community leaders, are full-time leaders, and then they find, I don't know how they find, you all find the time to do everything else that you're doing. But to be kind of co-sharing in the decision-making at the highest levels means that one or more people, right, are serving as sharing the leadership, and in this case we call it principal investigatorship. So co-principal investigators mean that more than one, and in this case community engagement, perhaps one community and one university are equal in their leadership at their level. They're commensurate then with whatever the resources are needed to bring that. And then they bring, I think what's important is collaborative and supportive roles to each other, not duplicative. You don't need two Soras doing exactly the same thing. No funder is going to want that. They're going to say, why do we need two Soras? We can only fund, we can just fund one. So they have to have, collaborative, but different, but supportive roles. And so often at times that could mean, I don't know, community report backs, right? Might be more of a community co-PI lead, whereas, I don't know, scientific conferences could be more of a university co-PI lead, but everyone's collaborating on it so that we're not, we're involved in all of these things, but with separately in terms of who's leading the facilitation of this.
Thank you. And then I'm going to wrap two questions that are in the chat together, because I think you might have covered some of it, but and I think you wrote a little bit of an answer in the chat, but can you share the process of what WinCart's community engagement plan included leading up to the NCI research proposal? And then the second question that came after that really reflects on this, which is how has the community engagement brought about co-design of program implementation and sustainability of funding to impact the broader healthcare in the community?
Yeah, let me answer that last question first. I think it's really baked into the conversations that are crucial to community engaged and community collaborative research development. You're asking the questions, not only what is the research question, but why that research question? What does the community want to do with the answers to this that will help in terms of maybe the community already has capacity. I mean, I look at the regional PI task force, I think the community already has capacity, but maybe there's something in the strategic plan that folks are wanting to get to, that the answering this research question and undertaking this research effort will help to advance. So sustainability should be baked in. I think a lot of us just have curiosities about things, and that could be enough. Like, okay, we just need to know in order to advance a new advocacy agenda or something in the future that we're not quite sure of. So the sustainability plan doesn't have to be completely clear, right? But I think linking the research endeavor to something that will be of service of community is crucial. And the way you do that planning takes time. So in the case of the WinCart Collaborative, it took us a year. We knew that a request for a proposal was going to be released by the National Cancer Institute in about a year's time. We knew that was coming up because they had already said that they were going to refund this particular mechanism that we wanted to go for. And so we started a year before and we just said, okay, what is the interest? What are the topics? How might this be structured? Who wants to be involved in this? Who should be involved that's not at the table? And then how do we resource all of this? We had 2 rounds of 5-year funding. In the second round, it looked slightly different than the first round because we undertook the same questions again. We didn't assume that everything worked the first time. And we said, do you still want to do it the same way? In the first round, for instance, we had one lead community organization that then subcontracted out to all the communities. And the same thing on the university, one lead university organization that subcontracted to all the universities. In the second iteration of WinCart, for instance, it turned out that every community wanted their own separate subcontract. They still wanted to go through the university, but they wanted a separate subcontract directly from the university. So we said, okay, how would that look? What would that mean in terms of invoicing and payment time? Are you okay with that, et cetera? And then we mapped it out. So in both cases, it took about a year to have the conversations around research questions and sustainability issues, as well as budget planning and structure.
And I think we have time for one last question. And I see Jake just threw something in the chat. Jake, do you want to unmute? Or otherwise,
sure. Yep. I just wanted to ask about what the community discussions looked like around mutual benefit. Only asking because in my experience as academicians or researchers, we often feel like just having new findings or just adding knowledge to the literature or to the knowledge base is a fantastic benefit. But in reality, to communities on the ground, there are often other priorities and or understanding of that as an actual benefit. So I was just wondering what that conversation looked like, and what did communities or members of the task force or different congregations really feel like would be beneficial to come in as partners in this, community-based participatory type methodology.
Wow. Hi, Jake, and thanks for that wonderful question. Chao, I think I'm going to turn this to you, because if I recall correctly, you came to me with the idea for this research project. And so I assume that you had some of these conversations already as to why this topic, what was the community's interest in it, right? And the benefit beyond, like Jake was saying, just new knowledge. Do you want to share any of that insight?
Sure, I'm going to give it a, I think when we started, before reaching out to Sora, we had, we're trying to lose weight, so we had a Biggest Loser, and we started the Biggest Losers for everyone in the church trying to lose weight. And one of the things that we always knew Sora was doing a lot of, the Wing Cart project. And with Roxanne, I was like, wouldn't it be great if we did something, along here? So there was an opportunity given to us by Dr. Rhodes. Say, hey, there's this, there's this grant here that, maybe you guys want to look into it. But before all of that, the church had already begun, having these workouts, the fitness program and how to lose weight. It was already, built into the church and the conversation. And with the health ministry and really integrating health into the ministry of the leaders, all of those in combination of all of the things that we were working with and the partners with UCSF, those conversations sort of blend in, because it just matched and would fit right in, because there were all of these opportunities that were coming in. But we had to figure out a way, how do we engage our community so it's easier for them? And then right when the Biggest Losers was ending, we wanted to do more, and then more in really engage and make something out of that. And so when the opportunity came up, we got together, we called up Sora and said, hey, we put together this quick proposal, look at it. We have about an hour, because we couldn't find a principal investigator to help us at the time. And then that's how it happened. And again, it's always understanding what we already know on the ground in the church and the congregation. We had the church, and the church was already working on these fitness, the Biggest Losers, but we wanted to go more, to do more from that and sustaining that piece. I'm not sure if I'm answering the question, Jake, but that's sort of like the genesis of how we started out,
Thanks, Chao.
So we've got just 3 minutes, and we do want to make sure that we capture a good number of surveys, because we want to bring you what you want to hear, what you'd be interested in, and what you would be willing to invite 2 people next time to come and talk about. So please capture that link in the chat and go ahead and fill out the survey. And I see Sora has responded to the one last question that we did not ask out loud. I want to thank everybody. I don't know if Sora, if you have any last words to close us out, but I think we've come to the end. Really appreciate you being here. Just want
thank you.
Any last tips for our young investigator and community members who are on?
Well, I will say that I think it's a very, very important role that you play, Kim, in facilitating a lot of this. We might not have said explicitly, but I think Chao implied was that actually it was Kim who helped to navigate the task force to me, and with the idea of building it upon some best practices, including, for example, body and soul, that has been successfully developed and deployed in African American communities. So if there's any take home message for many of you who are interested in engaging with researchers in the future. Make sure that Kim is on your target to ask the questions about how might you find, if you don't know already, how might you find researchers or communities who can be potentially collaborative partners.
And hopefully we can build that out even further as we collaborate as UCs, and then even bigger as we collaborate in the Health Equity Action Network across the country. I want to thank everybody for being here and for continuing to stick with us and for giving us your feedback and helping guide what we bring to you. I want to really thank again Sora and the folks from the Regional Pacific Islander Task Force, anyone who's on from WinCart, and all of your community partners who are willing to be here and share the experience and provide some guidance for how we can be doing this kind of collaborative work in the best way possible, the best, most equitable way possible. So thank you once again. Thank you, everybody. Please fill out the survey. Let us know what you want to hear next, and we'll see you again on October 18th.